as in we know the head and neck region is integrated structure wherein our dental or the oral health is already in sync with the tongue, the ears. So we try to cater to the needs of the patient so that the holistic environment is provided to the patient. So here we have collaborated with the speech and audiologist, Mrs. Jasna. To introduce Mrs. Jasna, she's an audiologist and also an applied psychologist, along with an expertise in the speech and language pathologist. And she's also done a fellowship in her head and neck rehabilitation of patients. So we as dental professionals, when we are seeing pediatric patients as well as the geriatrics or the adult patients post rehabilitation or post stroke recovery or the post facial nerve palsy, we do have to sink in or merge with these specialists, because our duty is only to restore the rehabilitation in the matter of form. So functions as pertaining to the tongue functions or the dentition usage or even the audiology, we have to interdepend on the specialists from the speech language pathology or the audiology, as also the psychology, which Mrs. Jasna's expertise in herself. And joining with Jasna is Afreen Salim, who's a speech and language pathologist specialized in oral placement therapy. Now, oral placement therapy is very new, and only few professionals in India. And luckily, in Bangalore, we have at least 3 professionals, one of which is Afreen, who's reached level 2 in oral placement therapy. This is an integration of audio, visual, and tactility, wherein the speech is enhanced for the pediatric patients with cleft lip palate post-surgery, or even the stroke patients, facial palsy patients, likewise. So as well, she's also a fellowship expertise in head and neck rehabilitation, as well as the other orofacial muscular defects, whatever possible. And paneling all of us will be Miss Dr. Amina Sultan, all the way from Delhi. She's been generous and, as usual, Dilwali, to be sharing her time, expertise for the topic, and also been kind enough to groom us for the presentation, has been walking through the slides. And let's see how it goes. So handing over to Mrs. Jasna Usman to take over and start sharing her slides. I request all the participants to mute yourself, and we shall take over all the questions after both the speakers finish their talk. So first we start with Mrs. Jasna, followed by part 2 in depth with Mrs. Afreen, and then the questions will be taken care and expertise will be shared with Dr. Amina Sultan. So take over, Mrs. Jasna.
Thank you so much, ma'am, for the kind introduction. So I'm here to present regarding the importance of dental examination in speech, language, and hearing. So what association it has got. So basically, we all know what is oral health. So you know it much better, and I do not have to explain in depth. But why is this very important is something that we are going to look into. So oral health and hearing, is it related? So what has it got to do with the hearing health? As we know, the normal auditory process, it moves from the external ear to the middle ear and to the inner ear. So it's a step-by-step process that is being followed. But what has it got to do with the oral health is something of interest today. The dental issues like the periodontal diseases or the dental infections and the abscess, etc., that can develop will definitely create the bacteria to proliferate, which is very harmful. And this harmful bacteria will develop all around the teeth as well as the gums, and it enters into the bloodstream, which will cause a lot of inflammation and narrowing of the arteries and the blood vessels, which also includes all those things that are very, very important for hearing. Because the outer hair cells and the inner hair cells plays a very major role in hearing in the cochlear area, which requires healthy blood circulation. They can damage all these areas, and it can even damage it permanently, causing the blood circulation to go very low. And this can affect and also cause hearing loss. Some of this hearing loss can, definitely happen due to aging most of the time, and also because of the normal situation that we see because of a lot of noise pollution. But when we have an opportunity to improve the dental health and to gain back the hearing or maintain the hearing health, then we have to definitely look into this. Moving on to next. So most of the times nowadays, especially, we get a lot of cases with sudden hearing loss. So I do associate that maybe one of these reasons could be poor oral hygiene or not maintaining good oral health. And definitely, as I mentioned earlier, noise-induced hearing loss is a major factor these days. So when these issues can also, enhance these hearing losses. And this can happen across all the age groups. So the next thing that we have found is most of the time, the eustachian tube patency is also being affected due to poor oral hygiene. How is this? This is because most of the time when there is a caries or there is a root canal treatment, which the doctor has advised, most of the patients, most of the time, especially in the Indian scenario, as much as possible, they try to maintain chewing towards the better side, and they ignore the side which is having the problem. So because of this, the chewing, which is being enhanced only on one side, the eustachian tube, as you all know, is connected. It's being not used much. So because of which there is a lot of pain which is being developed, and this eustachian patency, tube patency issues are being developed too. As eustachian tube patency is being affected, the balance of the body is also getting affected. So it's very important that anytime there's a patient that comes to you either with these complaints, it can be most of the time the patients also get confused. Is it a dental related issue, or is it ear pain, or is it something to do just with some neck pain? So they come with different complaints. And at this time, what we noticed was the main issue was the dental caries, which has been ignored, or they have stopped chewing towards that side, which has caused the major issue. So you can just see that the oral health, how important it is. It affects the hearing, and definitely, as we know, without good hearing, good speech and language development and good speech and language in usage is definitely not possible. And the moment the speech and language is being affected, there is a lot of cognitive issues and behavioral issues, and it affects the overall social health. So as an SLP, why is oral health again of importance to me is because in cases of head and neck cancers, it is very important to maintain good oral care throughout the cancer treatment and also during the speech therapy and the feeding processes. Because the chemotherapy drugs can cause a lot of sores in the mouth and also in the throat areas. It can cause a lot of dryness, bleeding, irritation, because of which most of the patients will ignore, and at that particular point of time when they're going through the major process, the difficulties with cancer, they do ignore the basic oral health. So it is very important for us to educate them regarding this, so that their further steps and also as much as possible for them to eat well and to speak well, etc., and also to attend the therapy well can be enhanced. So now again, oral health is very, very important in differently abled kids because they do not cooperate. Most of the time, the food pocketing is happening. And as you know, they do not like to swallow sometimes. And all this will impact the quality of the speech. And also it will impact their mood during the speech and therapy sessions. So when they are having these caries, most of the time they are already distracted. This will enhance their distractions, and they will not be very, whatever the benefit that they would be getting through the therapy process will also get restricted. So it's very important to educate them also regarding the same, and also to maintain good oral health in these kids. So now in dysphagia management, how oral health is very important is because oral care for the dysphagia patients does not just involve simply cleaning the oral cavity, but also to prevent the aspiration pneumonia, which can otherwise be fatal. So something very basic, if not taken care of, can be even fatal. So that's something of interest again. And at the same time, it is related to improving the eating as well as the swallowing function. So the moment any child, even as in the previous case that I mentioned, if the child is having all these issues, they would not eat well. That will again affect their attention span, and they would not be healthy. They would not feel energetic to go through their daily process. This can happen not just with kids with disabilities. It can also happen if we do not pay attention to the oral health in normal children as well. So oral health has a very severe impact on the entire quality of life as well. As you know, because all these bacteria, again, as mentioned earlier, with respect to the hearing problem also, there are chances that it gets into the bloodstream, all these bacteria, and this can affect the heart as well as the nutrients and the oxygen process which is happening, and which can reduce and which can also lead to a heart attack. So how is this related to speech is because all this inflammation of the blood cells, the blocking of the blood supply to the brain is definitely going to lead, and there's a potential chance of stroke. So once the patient is having a stroke, definitely there are chances that they would be developing aphasia. There can be dysarthric issues that will happen, and there will be also a lot of hearing problems. So all of that is interrelated. So now the general concept that people have is it's okay, I don't have to maintain oral hygiene or oral health, I don't have any teeth. So is this true? Definitely not. Even if you have no teeth or you're wearing dentures or you're not, also you need to take care of your oral hygiene because proper oral hygiene is very important to reduce the risk of pneumonia, which is associated with dysphagia, which I mentioned earlier, because it can even be fatal. So it's always a multidisciplinary approach that we will be following. So we need to strictly follow the dental guidelines, and we have to create an awareness between the patients that come to us, or if the patients are coming to you, we need to help them out in understanding the basics of having a good oral health. Because this is just to summarize how they have the impact on all these issues. Now, what is very important is the role of creating awareness in because it's very important that the parents they think that the teeth is just something which is aesthetic, or they do not understand the importance that it have in chewing and swallowing and speaking, etc. It has an impact on improved speech and language development too. It's a very lesser known fact that the healthy development of even the baby teeth affects the child's ability to speak, because the child's language and speech development happens from the mom and the child is born, because the child is hearing a lot of words, they're going through a lot of motherly speech from the mother, etc. So when all these things are happening and they're trying to make the cooing, the babbling, the sounds, and they're trying to make all these production of sounds, they have these positionings that is happening, and that's how they learn how each sound production happens. So even if the baby teeth is not erupting on time, it does have an impact on speech and language as well as in the feeding skills. So it's very, very important to maintain good oral health even at that basic age, as tender age as well. And now, once we also teach our kids to have a good, healthy routine is being followed, once we try to inculcate this kind of oral hygiene habits in the children. And most of the times, parents don't realize this importance, so they do not even come to us. They're like, it's okay, it's the milk tooth, let it fall off, and then it will happen. But by then, what happens is the child learns a particular manner of or a wrong pattern of pronouncing or producing the particular letters, and that starts slowly affecting the speech of the child also. So it is something very important that has to be taken care of. And because and also with respect to the feeding skills, because as I said, it should be very healthy, the kids should be healthy, because this is the language process age. So once the child is distracted, they're not able to concentrate, so there's a lot of information which they're getting from the environment which is getting cut off. So the next issue is the open mouth approach that the children do have. So what happens is their teeth will be protruded, and there will be a lot of malformations which happen, which can be easily corrected, or if it is ignored, then it takes a real long time to get back to the normal. This open mouth approach promotes open mouth breathing also. So what happens is the gums gets dried out, and the tissue lining of the mouth also is being affected, which will cause again the natural bacteria to promote all the sorts of gum diseases, and it can also lead to tooth decay, and it can again go back to having all the other process problems that I have mentioned earlier also. So this can also affect the voice of each individual, and the phonation duration, the quality of the entire voice can also get affected. So now at times there are patients who come or the child says, okay, I can't breathe properly. So is that got something to do with the teeth? Definitely yes. The airway and the ability to breathe freely has a huge impact on the teeth. Free breathing or breathing with extreme difficulty through your mouth has an impact on the structure as well as the function of the teeth. And what happens is the facial muscles also gets affected. So all this, which is important, not just for chewing. So this facial muscle movements are important for the speech production. So All this mouth breathing definitely causes both dental as well as speech and language issues. So the mouth breathers will also start developing a posture of moving their head forward. And because of the same, what happens is the tongue is being protruded forward because they try to do this to get more air. So when they're trying to protrude their tongue forward for a longer period of time, there are chances that the teeth also get pushed forward. So the alignment is getting affected, and this will also lead to an open bite. So all these normal postures also gets altered, and as you know better, there will be narrowed arches and misaligned teeth, etc. All this is going to impact the speech quality. And because of all these aesthetic problems also that they develop, they lose the confidence to speak. So that again has an impact on each individual, on their behavior, as well as cognition, as well as they will have a lot of confidence issues. So this can lead them to not interact well in the social gatherings, etc. So a lot of basic things which we can tackle by taking care of the oral health and starting off with good amount of oromotor exercises will definitely help the patients do better. So cleft lip and palate, as we all know, is one of the major issues that the dentists deal with as well. But over here, what is important for me is most of the times once the surgery is done, the entire rectification does not happen just by the surgery because it again depends at what age it has been identified and how fast the surgery was done and how well that was done, etc. So there can be a lot of issues with feeding as well as speech and language problems can develop. There can be a lot of production errors. So sometimes it is, most of the times, especially in the rural areas, they do not get the idea that, okay, there are speech therapists who can help them out. Or there are so many patients who have come as adults, and then when we ask them or we tell them, okay, this is this, because by then they might have learned their own pattern of speaking and things like that. And to correct it, it takes time, but definitely it is so very important for us to be aware that we give them the proper guidance once the surgery, etc., is being done, so that we are aiming at not just improving the structure, the entire function, not just about the swallowing, but also the function of all the things is for developing good speech and language and how they are being presentable to the others, etc. So all this will happen only if effective guidance is given to the patients, and that will definitely improve in therapy. And definitely at this point of time, we should have good correlation and we should be coordinating with the dentist so that we know exactly where we are falling short or what is the exact reason that the child is not picking up, or if they require any alternate treatment or any uh, uh, other assistive devices, etc. So we can have a good go in that if we coordinate with each other. So coming to the next, again, as we know, tongue tie is one of the major issues that the dentists come across. And even we get patients with a lot of misarticulation problems, etc. So the normal layman concept is that the tongue tie, it has got nothing to do with speech and language. It's okay. It's just a tongue tie. That's it. Maybe there's a little lisping or the clarity is affected. So people are not much conscious about it or they're not aware about it. But it is very important to know that even a child with a tongue tie, just as soon as the child is born, the mother has a very hard time in latching the breast and feeding the child well. So because of this, but the child is not able to latch over, the child is not able to feed well. So this is definitely going to affect the child's development process. And this is going to have a lot of impact on the mother also, because she's not able to feed her child and the child is not drinking milk well. So all these things will affect the mother mentally. So the minute the mother is being affected, she is not going to talk much. It's because she's already under some kind of depression. Definitely after the delivery process, they are already in a different phase. So all these things are going to add on. And the moment the mother is going to talk less, the very important essence of the mother is being lost. So that will again affect the child's speech and language stimulation, and that is also going to be affected. So this basic tongue tie, if identified at the earliest, there are a lot of things that can be overcome, and it can also help not just the child but the family entirely, because at that point of time the mother is definitely the basis that we have to take care of. And this is just as I mentioned earlier, like how important it is to coordinate with a dentist so that we are being guided in the correct path throughout the therapy process. The next issue that most of the time that we see is the tongue thrust. So this is also very important that we identify early. And most of the times, because of this tongue thrusting pattern, or because they have a very weak motor system, or the oral structures, muscles, etc. Most of the time, what happens is they're not able to chew well, they are not able to sleep well, and because of this, even the oxygen supply that has to go to the brain is also getting affected because they become mouth breathers, etc. So all these things, if assessed well, can be and if the oromotor exercises are being started on time, there are a lot of issues that can be tackled, and this can improve the child's overall health. So moving on to next, now what are the voice quality and cavity? Does it have a correlation? In general, if you think, no, what does it have to do? But definitely it has an impact. When it comes to the children's ability to speak, their water intake plays a major factor. Water is very important for our voice also because it helps us to use our voice successfully. So anytime that you come across kids with all these lot of even the a lot of oral cavity issues like the dental caries, etc., can be prevented if they're taking good amount of water and they're avoiding all the soda or the other sugary products, etc. So all these things which can affect the oral health of the child can affect the voice. It's not just the speech and the language. So it's very important that we have to guide them to drink sufficient amount of water, not just to just brush it once or twice and then leave it, but all throughout the day. It's a process that has to be maintained. So now, stuttering, definitely we do not have a pinpoint reason for stuttering, but definitely it has something to do with dental issues as well. So stuttering, because it's something that is going to definitely affect the patient's confidence. There has been studies that say stuttering can also be associated due to a lot of sensory issues. So sensory motor and tactile deficits that will impede the accurate timing of the tongue and the movements that happens. So it's an overall process. The mandible, the lips, the tongue, the teeth alignment, etc., is all coordinating. So even if the patient is having some kind of dental issues at this particular point of time, so it's always important to have an assessment, because this is something that we normally do not do. Even as speech pathologists, we do not refer to a dentist and just ask them if it is everything is okay. So what I understand from this is that it is at least one time consultation with the dentist to make sure, okay, if there is something that they could assist us with or they could help the patient with, and if you're going to start off with a speech therapy followed that particular treatment or line of management, definitely the effectiveness is going to improve. Now, screen time and dental issues, most of the time, definitely we do say that, yeah, speech is getting affected, the cognitive thinking is getting affected, language, they're putting the music so high or they're listening at a very low, a high volume for a longer duration of time, the hearing is also affected. So the screen time is also affecting the dental, and it's having a lot of dental issues as well, because the child, they keep on eating. There's a lot of binge eating which is happening when they're watching a lot of videos, and most of the advertisements that come across will also enhance them to go through all the things that they are not supposed to otherwise say. So all these things are also going to affect the oral health of the child. So when, as I said, once the oral health is being affected, it has an impact on the speech, the language, etc. So any child who comes to your clinic also, and they give a lot of history of any screen time and things like that happening, or they're frequently coming to the clinic with a lot of caries and dental issues, we can definitely look into their history a little, rather than just treating them just at one level by asking, okay, what's the issue? Let us also try to find out what is the reason that this particular child is getting a lot of caries all the time, and why is that this child is coming with all these problems. So just to have that insight is why I mentioned screen time is also a problem for the dental issues. So now the role of oromotor examination is, as I mentioned earlier, the oral examination. Once it's done, the oromotor assessment, the movements of the muscles, the overall. So what happens is most of the time the child comes, especially in the Indian scenario, they do not come at the earliest when they have any basic issues. So most of the time when they really feel, okay, now it's not at all aesthetically appealing, that it is too awkward, or then or the age is crossed, and then they come to you after a long time, and they have to spend a lot for all the kinds of orthodontic treatments. But if you exactly see, if not in all the patients, most of the patients might be having some kind of oromotor weakness or restricted movements that is happening. And that is the reason for the protruded teeth movements, or they're all the time having a tongue thrust, etc. So all this can be definitely improved with good amount of oromotor exercises once the examination is done. So if we can know the cause, or you see a basic level issues which do not require, you could say that maybe you can wait for a while before we start into a detailed orthodontic treatment. Before that, it's good that we can have a coordination between us, and we can do the assessment, and if required, the management can be taken over, and we can even see whether it's progressing. So this has been started by a lot of dentists and speech pathologists across the state. So this is definitely showing a lot of improved results, is what was the feedback over the period of time, what they saw. So now again, the anterior or the posterior teeth. As I mentioned earlier, again, the Indian setup, they try to maintain all the problems as much as they can. So what happens is the moment, even though the speech production or the sounds are being articulated, etc., by the anterior teeth, most of the time the tongue touches the anterior teeth. But definitely the posterior teeth is also very, very important for the clarity and the quality of the speech, especially in the adults also. So most of the time they try to take care of the anterior teeth, and most of the time they'll be like, okay, just take it away. I'll remove my posterior teeth, or I'm not bothered that it's there or not. But that's not the concept. It's very important to educate the patients regarding the issues that they will have with respect to not just speech, but with respect to chewing and their feeding skills. All that is going to get affected very badly. So both anterior and posterior teeth, it definitely plays a major role in both speech, in the speech and language. So now to give you an insight on what are the basic factors that could be affecting on the speech and language development. So this is basically because even if the patient comes to you, or you see the patient having a child who is having these problems, etc., you can give them a guidance. So they could be issues with speech and language most of the time when they are in the nuclear family. And if you're seeing some children who are not talking age appropriately, then definitely you can guide them towards speech therapy. As well as if the moment you see a lot of, you are seeing the teeth is all fine, the tongue is fine, the movement is fine, still they have a lot of unintelligible speech, they have production errors, and they come to you, you can guide them again. Again, as I mentioned earlier, the voice quality is sometimes affected, and you're not able to understand what they're speaking, or there's a lot of strain in the child's voice or the others, etc. You can be careful about that part also. Again, if the child is being exposed to multiple languages, there can be a chances that there is a speech delay. And as I mentioned earlier, again, the screen time. And again, if you see that the interaction of the parents is very less with the child, so at this point of time, you can give them a guidance. Again, the other things that can also affect is the shift in the place from a rural to a urban, or they shifted the school. So at that particular point of time, also there are chances that the child is affected psychologically, so they're not adjusted. So there can be issues with the speech and language. The sudden environmental changes or any kind of unpredictable incidences that happens, maybe a death in the family, etc., can have an impact on the speech as well as the voice quality of the child also. Sometimes it can even be functional. So if you see any such cases coming up to you, it's very important to know that these are some of the reasons that has caused these issues. So even there can be some children who are otherwise smart, they play really well, they are able to indulge in all kinds of activities, etc. But their academic performance is most of the time affected. So at this particular point of time, you need to definitely guide them for therapy, because that will definitely improve these kids. So now the entire aim of us to be over here is how do we both benefit as dental professionals as well as a speech language pathologist. How do we help each other by knowing, okay, we know these are the problems. So one thing is, most of the time the children, so even if it's not a child who is having any kind of disorders, it can be even a normal child. So sometimes they will exhibit challenging behaviors. They'll be very, they will be very arrogant maybe, or they're not wanting. They'll be sometimes very hyperactive, and they can throw a lot of tantrums. So at this particular point of time, so how do you improve the oral health? Or when maybe they would ask you, like, he's just avoiding, he doesn't want to brush the teeth. So what do we do? So most of the time, as a speech pathologist, what we would say is to model their behavior. So that is by, okay, just tell, you see, mama is brushing, and then you also do the action of the brushing. So you can tell the patients to do such simple tips. And, can you see what am I doing? It's a language process also which is happening. There's an action which is also involved. So the child sees you, and then they definitely try to imitate you. And always the child has to be given correct instructions. And it should be always a step-by-step guidance that is being happening. So even though we see the brushing as a very simple process, but we need to tell them what are the process involved. And it's also by gargling the mouth first, and again, how do you apply the paste, etc. So you need to help them out by taking some amount of time. And it's very important because in the initial days, even the normal child, apart from the differently able children, also they require a little bit of practice. And with practice, definitely they will attain this kind of perfection. And most of the time, they require a lot of repetition. So it doesn't happen like, okay, today, even with normal kids, it doesn't happen like, okay, I'm going to start making them brush the teeth, and today it's going to start off. But that's not possible. It definitely takes a lot of repetitive explanations, and we have to be patient enough. And especially if the child is having a problem, then we do focus on giving them a lot of praises or some amount of reinforcements to the child, so they feel good about the activity that they have done. So they can be shown some pictures also about how the brushing is happening, or you can tell them some simple stories regarding it, or this could be, they could play some videos regarding it, etc., so that the child is being motivated. And also, we, as a speech pathologist, we do a lot of role play. So the same thing can be done with respect to the brushing pattern. So you can guide your patients who come, the mothers who come to you telling that, we are having a tough time making him to brush the teeth, etc. So the role playing can be like, okay, you tell, like, you be the child, now you tell me how do I go about it. So they find it very interesting. Okay, you are going to give mama a brush, you are going to make mama brush today. So how are you going to do it, etc. So it is an interesting process, and then they will be finding it more interesting to go ahead with the thing. So moving on to the next is, I just told you regarding the instructions. So every time, this is not just for the brushing process, for every kind of activity that the child does, instruction plays a major role. This is not just again with the child with disability, but even in kids, normal kids, you can apply this. And of course, we all have kids, so we can definitely try implementing some of this. So it's very important to make a note that whether the child is attentive. So you're going on giving your instructions, and you're not looking at the child, and he is maybe watching the video or doing something else, then there is no effect. And then you get angry later on. So it does not make sense. So we should make sure before the instruction begins that both of you are attending to each other. And it's very important to call out your child's name, or in general, whenever you speak to your kids. So if you call out their name, there is a chance that they would be paying more attention to whatever you're trying to convey to them. So rather than all the time telling, look at me, look at me, look at me, they were never going to look at you. And especially that you told them, okay, look at me, they have no interest to look at you. So go to their level. You can just go to their level, try to look where they are looking, and then move yourself towards their level, so that it becomes more interesting for them. And then they will follow what you're trying to say. This can be also applied with respect to teaching them to brush their teeth. And then the instructions should be always clear and calm. So if you're talking in a very frustrated tone, you're raising your voice, and then you're trying to bring to their attention the basic things, that is very difficult. You can also incorporate some amount of gestures, some funny movements, so that they find it very good. And rather than giving a negative feedback most of the time, oh, what did you do? This is what you did. I didn't expect you to do this. Rather than that, it's very important that you give them a very positive feedback. Okay, you did a good job. I saw that your teeth is much cleaner today. It's sparkling, and then maybe it can be a little more cleaner tomorrow. I think so. Or maybe let's try it again at night, and then just give them positive feedback so that it will benefit. So these are some of the takeaways that will benefit you too. So other things is with respect to the grasping and holding. Maybe the child is not able to brush because there's a difficulty in the grasp. So we have to take the physiotherapy assistance. And then the other things that could be issue could be the taste, because especially with children with autism, and sometimes yes, even with Down syndrome. So all these kids, most of the time, the moment they have the speech and language issues, definitely there is oral sensory issues that they are facing. But in autistic cases, definitely they are very picky with respect to the food that they eat, the flavors, the smell, the texture of the food, etc., is a major concern. So in this case, also with respect to the dental part of it, so there are toothpastes that are available in various flavors. So the mother who is very sad about this part of it can be given an insight into, trying to use different flavors that their child would appreciate. And also, maybe some of them would appreciate soft toothbrush. But maybe if the child is also enjoying it to be a little more in the medium quality, they can try changing that as well. So they can do these trial and errors and find out what exactly is causing this problem. And also the brush head size being smaller will be much more beneficial. And again, sometimes the lighting issues are a major problem, especially with children with autism. So they can also make sure the place in which they are in, the environmental factors, the place in which they're trying to make the child brush also may be affecting the child. So, and sometimes even the order that is being present in that particular area could be distracting. And that's the maybe some of the reasons that makes the child more cranky towards and having developing an aversion towards brushing. And in such cases, again, if at all you try helping them out with these guidelines and still they have issues, they do come back and tell you, no matter what I try, they are not able to accept the toothbrush or the face brushing behavior. Then you can guide them to us, wherein we will be assessing again. And also there are a lot of exercises which will improve their sensory issues, and then this brushing behavior can be definitely improved. So again, with respect to voice problems, especially if you're in a rural place and there is no speech therapist, etc., available, at least if it's too bad, you can guide them to have some amount of voice rest, and also make sure that they follow good amount of vocal hygiene. And the main vocal hygiene that they would follow would be to drink sufficient amount of water and to avoid all kinds of spicy foods and things like that. So these are the basic vocal hygiene that can also be guided to the child. And also if they are excessively shouting or indulging in a lot of speaking behaviors, they can reduce that as well. So these can be some tips that you can give on behalf of a speech pathologist from your end as well. So again, most of the time what happens, even till today, it's a sad reality that most of the structurers, they're not aware that they have a option of at least trying it out to have a speech therapy. So even if not 100%, at least they can definitely improve their basic condition, and they will definitely learn alternative methods of modifying their speech patterns, and this will definitely improve their quality. So you can do this kind of referrals also when issues with stuttering they come to you. So this was something that I went across when I was doing some kind of my research. So most of the time, the attitude this is very much applicable to the Indian scenario also. So this is to enlighten both of us, because we all are here, the speech pathologist as well as the dentist, that it's very important that we go hand in hand, because this was the summary of the study. I've just copied the same as it is. So the lack of awareness. So most of the time when the child has a speech problem, they sometimes go to even the pediatricians. They do say it's okay, you can wait, and we do not get the referral at the correct time. And there are patients who do say that, we had gone to so and so and so, but we never knew that I was supposed to go to a speech pathologist. So it's very, very important that we educate ourselves with respect to the options that is available, and to also guide, because as professionals, we here to help and to uplift the patient's health, not just with respect to that particular conditions, not just the teeth or just the ear. I gave a hearing aid and my work is done. No, it's the overall health and development, which is the improvement that will happen in the society. Should be our aim. So this is just a summary. So as I told, just this very basic thing, that is the maintaining oral health, will have an impact on the voice, the hearing, the confidence of the patients, etc. So the future goals is just to, as I mentioned earlier, to work hand in hand and to create a lot of awareness. And just as we do the newborn hearing screening, which was something which was never done in the past, it has come up really good, and we are able to identify a lot of children at the earliest age possible, and we are able to rehabilitate them, and with a lot of options of hearing aids and cochlear implantation right now. The children are able to develop proper speech and language, and they are having better intonation patterns these days, and they're able to mainstream them on time. So it's improving their quality. So similarly, just like a newborn screening, I think the dental examination should be included as an effective part of it. And once it's done, there's a lot of things that can be overcome, a lot of issues that can be overcome, and it can improve. So it's never late to make these corrections at any point of time. It can be definitely done, but it's always important to know the earlier the better. So thank you for patiently listening to me. I hope you benefited from my talk. So keep smiling, keep speaking. Take care.
Thank you, Mrs. Jasna. That was an excellent talk. I mean, a very brief overview. As you rightly pointed out, our integrated approach is the need of the hour today. And sometimes it is this, outcome of success. So the success only multiplies. And in this case, it's the patient's overall well-being. So without much wasting of time, I pass on the request to Mrs. Afreen to start share screen. Yeah. For that, Jasna has to stop her screen sharing. Ms. Jasna, if you can stop your, yes, thank you. Yes, Mrs. Afreen, you can take over.
Are you able to see my slideshow?
Slides, yes, not the slideshow yet.
Now, ma'am?
Yes.
Am I clear and audible?
Yes.
Good afternoon to one and all. Assalamu alaikum wa rahmatullahi wa barakatuhu. Ramadan Kareem. I request everybody to have patience with me. I know it's a little difficult. So today we are going to be discussing about interdisciplinary approach between dentistry and speech language pathology in treatment of patients with dental problems. Overview of my presentation will be that you will be taking away a few red flags or a few highlights wherein you'll be aware that, okay, when this patient walks in, you will be at least 50% of the time, I hope so, you will be able to catch that this patient is at risk or is having some amount of speech and language problem along with communication issues. So moving on, why is there an interdisciplinary approach needed? Is because adequate treatment of dental and oral conditions will help in better myofunctional development of the child or myofunctional alteration in the patient, which directly affects their oral health. And then the oral health, and it leads to a favorable prognosis in terms of dentistry. And in terms of speech language pathology, we can look at speed, range, and strength of muscles that are needed for chewing, swallowing, and speech. These are the common structures that are associated with both our professions. So when there is a proper and adequate treatment given to these structures, in turn, our speed of movement of muscle, range at which the movement of muscle can go through, and the strength with which the muscle can move can be improved. So our functional part of it will be chewing, swallowing, and speech. And of course, articulation of sounds. By articulation of sounds, I refer to when two structures meet. When two structures meet, and then there's a sound that is produced that will furthermore combine into a word, and then furthermore it gives it takes up into cognitive aspect of it, and then it is a language. Like now I'm going to say pa. My two lips are going to join, and then we say pa. So that is an articulation of sound. When you say papa, it is your father. That is the cognitive part of it. If you just say pa, it is a non-speech sound or a nonsense sound or anything which has no particular meaning in that particular language. How can caries affect overall speech and swallowing development or skills? Caries cause a lot of pain, in turn difficulty in chewing and swallowing. Therefore, the end result is low nutrition and reduced development in the patient. So speech is an overlaid function, and before speech is achieved, there are few basic functions that the baby or a newborn has to perform. So these are speech is an overlaid function. So these are stomatognatic systems, and our morphofunctional units in our case is oral cavity. These functions are breathing, sucking, chewing, swallowing, and phonoarticulation. Chewing in initial stage is an initial stage of digestive process, and it involves the further development of craniofacial complex, central nervous system, and dental occlusions. Although there are furthermore steps to digestion, but chewing is a voluntary stage of your swallowing process. Up until pharyngeal stage also, there is a lot of control that the patient, a baby, even a newborn also has a lot of control that they learn to control the food and manipulate the milk in their mouth. Here, I would like to mention that although missing of incisors in initial stages will only affect the temperature changes, detecting of temperature changes, or determining the consistency of your food or bolus, and things of that sort. Later on, missing incisors will lead to speech problem. I will be talking about the positions and sounds with which will be those sounds that will be produced with help of our incisors. So you can relate to it then. So stomatognatic system is for speech as an overlaid function. Premature loss of primary teeth also will result in low motor practice. Again, speech is a motor practice. It's a motor learned skill, and the more you practice, the more the child is able to practice these sounds through play, through talking, the better the clarity is. It is a skill that is learned over a period of time. So verbal language at birth is innate. There are innate structures in our brain that will help us focus more on language and not on non-speech sounds like a fan sound or a vehicle sound or things of that sort. And it gets verbal language gets complex as the child develops further. At 2 to 4 years, there is a 80 to 90% mastery over the phonological system or development. Phonological system here is referred to as the sounds that are used in that particular language. For example, if it is English, all your phonics and sounds, a, e, u, pa, ba, ma, or water. Water has wa, a, t, 4 sounds are there. These sounds are called the phonemes. when the child is able to actually acquire all the sounds of that particular language, this is what I'm referring to, when by 2 to 4 years, he's going to achieve the mastery over phonological system and development. Phonotactic rules and learning process, again, these are the rules with which the language is learned. There are particular set of sounds that can be combined only in that way. So that is how it goes. If you cannot combine sounds randomly and then expect it to be a meaningful word in a language, those rules are called phonotactic rules. Moving on to the speech and language milestones. At 3 months of age, cooing and gurgling is achieved. At 6 to 12 months of age, the child is able to babble. At 12 to 18 months of age, the child is able to say first few words. At 18 to 24 months of age, he is able to expand single word vocabulary. By single word vocabulary, I mean he may be saying amma or mummy or mama. He will be able to say mama come, mama give, or daddy, dada come, or dada want, I go, things like that. Expanding that one word to 2 word phrases, short phrases. So you see a child with a 2-year-old coming in and he's still not able to say. Maybe while you're taking your case history, if you are finding that the child is not able to say, you can just ask the parent or the caregiver if he's able to combine these words. General rule of thumb is that at 1 year of age, he should say at least one word. Carry me, or any simple things, you know, go, come. I'm using English as a language because I'm not sure if others can understand our regional languages here. Moving on to 2 to 3 years, forming 2 to 3 word sentences. Simple to remember. 2 to 3 years, they should be able to say, I go out, I want amma, I want food, or maybe want food, go, or want sleep. At least 2 to 3 simple basic demands that a child will need. That is what he will definitely say. A normally developing child would say these many things. 3 to 4 years, ask simple questions using longer sentences. So these are a little more in detail, the speech language milestones from birth to 1 year. At 0 to 3 months, he makes cooing sound. They may be saying coo, and things like that. Cries differently for different needs. There are different types of cries. Pleasure cry, hunger cry, sleep cry, and the child, a mother or generally or a parent will definitely recognize that cry is for what. There will be different sounds that he will be making when he is actually sucking on mother's milk, or when he is taking in food, although there are no proper words coming out. The development has not reached so much that he can actually say, oh, this is so good, oh, I like it, or I don't like it. But these sounds generally are there, and they will, you can recognize it very easily. Happy cries. So these are the things that you can see at a very young age of 3 months. Cooing and babbling at 4 to 6 months, you can see cooing and babbling. Make sounds like pa 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 ba 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 brr, and blows raspberries, grr, ka ga ma mi, and he giggles. Of course, at 3 to 4 months, they are going to learn how to smile, look at the caregiver or anybody who takes them, or makes upsetting sounds if they don't want to be with that person. And these are the things that you can see. Of course, I'm not sure how many of this age range population come to dentists. But when we talk about tongue ties and other issues, furthermore, you can actually relate these milestones with that and then correlate, because everything is related. You miss out one small aspect, it it does lead to a bigger loss or miss when they grow into childhood. So 7 months to 1 year, the infant is able to use sounds and gestures to get and keep attention, get their help. They are able to ask when the child is lying down. They are able to show through gestures, carry me. They'll move their body. They'll arch their body, kick down, and all that. You get to know that he wants to be picked up. Their demands are fulfilled. So these are small things that you'll notice in a typically developing child, and these things will be missing in a child with a developmental disability. So points to objects and shows them to others. They'll generally look at those objects and look back at the caregiver or the new person, whoever it is. Uses gestures like bye-bye, reaches for up, shaking his hand to say no, pulls and grabs the bottle to their mouth if they are bottle fed or they're taking the spoon. They are very meaningful and structured. Say 1 or 2 words like hi and dog, dada, mama, uh-oh, and things like that. That is at a later age. Between 9 months, they are able to say, above 9 months of age. 1 to 2 years uses many new words. There are studies that say that every day the child picks up approximately 50 new words. He's able to understand 50 new words every single day. So the amount of speech and language stimulation anybody can do to their child is remarkable. They can basically bombard the child with a lot of talking. Uses pa, ba, ma, ha, and wa in words. These are the easiest and more visual sounds. All these sounds are seen on the lips, so that's why they pick up. Starts to name pictures in books. Generally, whatever books you show, vehicle, car, and fruits, whatever ABC books, anything. They're able to look at them and understand and pick them up. Asks questions, what's that, who's that, where's Kitty? Puts 2 words together like more apple, no bed, want mama, and things like that. By 2 to 3 years of age, uses ka, ga, fa, and ta, and da, and in words. So these are a little more complex. As discussed before, the phonological system is developing, and as they grow up, they are able to understand and listen and put out motorically in these sounds. Uses words like in, on, under. Uses 2 to 3 words to talk about and ask for things. People who know your child can understand him or her. I think I don't agree with this particular statement. Even at the age of 1 year or 1.5 years, people who don't know your child, or they can also make out. They know what they want to say. The same thing is not picked up by parents with children with disability. They don't know how to say, so that is where the lag is. Put 3 words together, talk about things, may repeat some words and sounds. 3 to 4 years uses approximately 1,000 words on a daily basis, can answer simple questions, speaks 4 to 6 words in one single sentence, speaks clearly enough to for everybody to understand. But there is a, what do I say, todal, they say in our Kannada, or there is a misarticulated sound. Like for book, they'll say uk, car, they'll say tar, and things of that sort. But the overall meaning as such, even a new person can understand. Starts telling stories in their misarticulated sounds. This is all normal stage of development. Moving on to places of articulation, there are bilabial sounds. These are the first achieved sounds, pa, ba, ma, and wa. Bilabials are nothing but they are produced with two lips put together, and they are produced. Can you guide me how to use the pointer? remote control, is it? How do I use a pointer here?
The point is in the option of the share screen. I mean your
Annotate.
Yeah.
Acha.
Your PPT.
Okay.
If you click in the options of the PPT, you'll have the laser pointer.
Okay.
Slideshow.
I'm not able to get it. Either ways. Okay.
You have an option of a pencil on the screen. You can use
annotate,
it to draw it.
right?
Yeah. You can use it to draw it on the thing. You can always delete it.
Okay, so bilabials are these when the two lips are put together to produce pa, ba, ma, and wa. Labiodental are with lips and dental, fa and va. You put your lower lip onto the incisors and then you produce the sound fa and wa. Interdental is the sound that is produced with two teeth and the tongue. Ta, da, as in thank you, there, you know. Okay, 1 minute. Alveolar sounds are ta, da, sa, za, na, and la. Alveolar sounds, most of the time, they do get affected when the front teeth are missing. But there are many patients who learn compensatory strategies and they're able to fairly produce these sounds with fair intelligibility that the person is able to understand further. The person whomever they are talking to, they can understand. They do learn compensatory strategies. So like Jasna had told earlier, these can be advantageous and disadvantageous. Advantageous in the sense that, you know, they don't want dentures or the person is able to understand their speech. But when it is a wrong pattern that is learned, motor learning is done in a wrong way, it is very difficult to unlearn them. So early intervention again plays a very important role here. Post-alveolar are sh, z, ch, j, and r. And then palatal sounds are ya. Velar sounds are those sounds that are produced when the back part of the tongue touches the velum, the soft palate. Ka, ga, and ng, like walk, ing, ng. The ng is the walking, sleeping, talking. Ng. Glottal sounds are ha. Glottal is just the vocal folds will vibrate. Is the slide moving? It's not moving. Is the slide moving?
No, it's not.
Okay.
Yeah, it's moved.
Okay. So manner of articulation, these are place of articulation, from where these sounds are produced. Manner of articulation is basically the way these sounds are to be produced. You can just put any two articulators together and produce any sounds. But the way it has to be spoken, that's when you give meaning to it. So pa and ba are stops. Stops are basically those sounds that need to be stopped completely. Speech is an output of an expired air from the respiratory system. So when you completely stop that air, pa, ba, ta, da, ka, ga are produced. Fricatives are those sounds that are produced with a lot of partial stopping with friction. Fa, wa, ta, da, sa, za, sha, ja, ha. Partial closure. Affricates are combinations of stops and fricatives. Cha, ja, there's complete stop, and then you produce it out with the friction there. Cha. You can actually say these sounds after me to understand. Ch, j, you're going to stop and then put out through friction. Nasal sounds, of course, they are produced through nose. Ma, na, liquids and glides are overlapping most of the time. They flow. easily. That's why they are called liquids and glides. They don't need complete stopping at any point or complete stoppage of the expired air. L, r, w, y. Place of articulation, you can just remember this pictorially. So this is how the lips will look like when these sounds are produced. So most of the sounds by the age of 2, 90% of the children will achieve accurately by mastery of phonotactic development and phonological development. This is what I was referring to. By the age of 3, they are able to say b, m, h, w, n, t, d, k, g, f, y. By the age of 4, they are able to say s, z, sh, ch, v, and la. R and th are the most difficult. Sometimes they are able to learn by the age of 6 years also. Phonological processes and phonological rules and learning process. There is a small very thin line of differentiating between normal and the disabled population in these things. Phonological processes, a normal 2-year-old child can say tar for a car, but the same thing cannot be said for a child who is 6 years of age. A child with 6 years of age says tar for a car, definitely, you know, there is a problem. So this is just to put on light and awareness, so you guys can pick up when the child walks in, a 6-year-old having a articulatory disorder, not talking well, you can pick it up. So they usually use simplification of sound. They are systematic, universal across all language, be it Indian languages or even other languages. Phonological rules, there are rules with which they are followed, it is affected, then it is called phonological disorder. This is characterized by substitution, omission, distortion, and that the child performs during speech acquisition and while he talks. These alterations may be related to cognitive, linguistic difficulty associated with sound perception, again, sensory or motor. We will be further discussing in detail. So there are more than 40 phonological processes in any language system, but these are the most commonly found and commonly picked up phonological processes. When it is when it is there within that age, like age of elimination is also written, that is normal. Anything beyond, at least at 3.5, he is having assimilation, then it is something that needs to be addressed. Assimilation is that for hat, bub for bus. Final consonant, these assimilatory sounds are eliminated by the age of 3.5. Final consonant deletion is the last consonant, the last sound is deleted. Cat for cat, ka for car, boo for book, da for dog. The last sound is deleted. So the age of elimination is again 3 years. Reduplication is wawa for water. Instead of saying dog, they may say dada or doddy. You know, there's a same sound that is repeated. So this is eliminated by 3 years again. Fronting is tup for cup. Again, it is eliminated by 3.5 years. So they are going to, like now, fronting means they are putting the sounds in the front. Front sounds are more easier. Like I explained earlier, these are seen more easily by the child. So they are using ta instead of ka for cup. Stopping, instead of sun, they say tan. Instead of run, they say tan. Okay, so they're going to use the stop, the sounds that I explained earlier. So all these fa, z, and sh, cha, and ya, ta, all these sounds will be stopped. Instead of saying shu, they'll say tu. Instead of saying chai, if they want tea, instead of saying chai, they'll say tie. Instead of saying van, they'll say ban. Things of that sort. I hope I'm very clear here. So this is, again, with these sounds, it's eliminated at fursa, it is eliminated by 3 years, versa, it's eliminated by 3.5, sha, cha, and ya are eliminated by 4 years, and ta by 5 years. Syllable deletion. Together, one syllable or one set of sounds are deleted altogether. They'll say nana for banana, and this is done by 4 years. Cluster reduction is reducing of cluster sounds. Sa, okay. Sa and pa are together, put together, are called spoon. They'll say poon for spoon. This is eliminated by 4 to 5 years. Gliding, they'll put a glide instead of the actual sound. So weg for leg, one for run. These are eliminated by the age of 6 years. Like I said, by 6 years also, they're going to learn how to say ra. So here also it falls in, everything falls in sync. That's why if one aspect is missed, it may lead to a bigger developmental issue. Most common disorders that are associated with common structures, in our case, oral cavity, are anatomic, motoric, phonetic, and phonemic. Anatomic is cleft lip and palate, tongue tie, lip tie. Motoric are dysarthria and apraxia of speech. Phonetic are articulatory disorders. And phonemic are phonological disorders. Anatomic part, cleft lip and palate, tongue tie, lip tie, I think Jasna has covered. I will be just highlighting them. So when you see orofacial myofunctional disorder, there is some problem when the moment you see the child you're doing, or the patient, you're doing your dental examination, you see some deviation in the tongue, some teeth are of course missing, that's why they're coming, or I may be wrong there. But you will see there is a deviation in the muscle tone. It's not, they have open mouth, tongue is falling out, tongue thrust is there, things of that sort. When you do see, you have to look into that, whether you can inquire with the caregiver or ask the child few basic things. What's your name? Can you count from 1 to 10? Can you sing a rhyme? You will understand the quality of their speech when you hear. So definitely then you'll be able to screen out that the child has age appropriate language and speech skills, and you will be able to refer. Velopharyngeal dysfunction, of course, there'll be nasal regurgitation and nasality and hearing loss. They'll come with a hearing aid, or probably they'll say that the child has hearing loss, or you will come to know when you're inquiring. So differential diagnosis will again come back to the same: articulated disorders, phonetic disorder that I referred to earlier, phonological disorders, that is sensory again, motor speech disorders, and mixed speech sound disorders, which we'll be discussing furthermore. Dysarthria. What is it? It is weakness in muscles used for speech, difficulty in moving tongue and facial muscles, rapid speech, difficulty to understand. They may be, these are problems that are produced due to weakness in the muscle. So that this is where speed range and tonicity of the muscle play a role. So it can be nasal, raspy, strained voice, speaking too loudly or softly. Generally, patients to mask their disability, they will try to overdo it. So you can pick those abnormal speech rhythm, slurred and slowed speech, and monotone speech. Monotone speech is, my name is Afreen Salim, things like that. By nasal, it will be very nasal. I'm quite sure many of you have heard nasal sounds. Strained voice is, my name is Afreen Salim. I am a speech language pathologist. Of course, speaking too loudly and softly, anybody can understand. and then there is no rhythm in the speech. There's no flow. The moment they speak, you'll understand, okay, there is some speech problem. So different types of dysarthrias are basically with respect to the neuronal connection. When there is a lower motor neuron deficit, it is flaccid dysarthria, and there is weakness. A spasticity you can make out when there is a spasticity in the muscles of our oral structures. Ataxic, there is a lot of incoordination. They'll say open your mouth, they'll be doing something else altogether. They'll be struggling to open their mouth. I'm just giving those examples that are that can be used commonly for both of us. Hypokinetic disorder, there'll be a lot of rigidity in the structures. They cannot open their mouth or close or bite or spit. Hypo and hyper both have involuntary movements. Unilateral upper UMN, of course, you can definitely make out when you see a unilateral upper motor neuron disorder. There will be a single-sided weakness, right or left. Facial palsy, you can see. You will see deviation towards your whichever side that is affected, right or left. Deviation of the lips, deviation of the jaw, deviation of slight deviation of the jaw. You cannot make out too much, but tongue and lips, velopharynx, and pharyngeal structure also you can make out. There will be a lot of difference in the way they move. They don't move symmetrically. Mixed, more than one of the dysarthria types. Moving on to apraxia of speech. This is a tricky diagnosis. Brain knows what it wants to say, but has problem coordinating with the lips, tongue, and jaw to produce and speech sound. Basically, when you're learning to drive a car, you know you have to press the accelerator, clutch, and followed by brake, and all those things you do know. But sometimes you, instead of pressing the brake, you'll press accelerator and things of that sort. But here, that is because you're either nervous, you're having stress, or you have some other factors affecting your thought process. But here, in this case, the brain knows what has to be done. There is no physical deficit in the muscle, but the way the information is passed down from the brain to the lips and the other structures, there the information is lost. Either when, for example, again, okay, you are asked a question and you want to say something, the brain finds the words to put them together in order. For example, I'm asking, what is your name? The brain is able to put it together. Okay, my name is Afreen Salim. The motor part of it, my mouth has to open for ah, put the lip on the teeth for fa, af, put the tongue near the palate for ra, afr, and you know, there's a sequence basically. But what happens is motor part also is prepared, but the message that is sent across is misled, and something else is said altogether in this population. It is seen both in children and in adults. So the message gets sent to the speech muscle and you say what you have to say, but the message gets messed up here. Apraxia messes up the message by putting things in wrong order. They may say rf in, or instead of Afreen, they say rf in, or something else altogether. So these are the overall symptoms that you can see. There is a breakdown in planning and programming, and often left hemisphere damage will be there. So on the right hand side, or the right leg and right arms, right limbs will be affected. So you will be noticing this problem in those patients. Key perceptual characteristics, because they know they have such problem, they'll start groping instead of, you know, going clean slate and saying Afreen. They'll be making mouth movements. Now, if, for example, there are different apraxias also, motoric apraxia, non-verbal apraxia. Like if you're saying whistle, they know the mouth has to go rounded and tongue has to go back and you blow out. But they will be searching for that position. They'll be doing you you know, I don't know if you're able to see my video, they'll be moving their face structures a lot more, although they know the same thing. If they're whistling to a sound, they will be able to whistle. That is the characteristic of apraxia of speech. When unconsciously they are whistling, they'll be able to whistle. Unconsciously, suddenly, you know, if they don't pay attention and there's a call, they will ask some detail, they'll be able to say, "Ah, my name is Afreen Salim." But the same thing on purpose, on volitional, if you ask, it is a problem. Automatic speech, they can tell better. Like they are rote memory, basically. Automatic speech can be Sunday, Monday, days of the week, months of the year, counting, alphabets, or singing. All these are better than the voluntary. You ask them to sing some song, that is a problem. So anyways, AMR and SMR are sequential motion rate and alternative motion rate. When there is uncertainty to it and they are not aware of it, they'll be able to do better. Inconsistent errors, like I said, once they'll be able to whistle, they'll not be able to whistle on command. Self-correcting attempts will lead to a lot of groping, searching for what position the lips have to be placed or the structures have to be placed. Articulation again decreases with the increased length and rate. It means that the more complex the sentence, the more difficulty they will have in speaking. They may occur alone or coexist with dysarthria, aphasia, and also it is very much seen in cognitive linguistic disorders like premature babies, even autism. There's a huge population of apraxia, huge population of children with autism who have apraxia of speech. Okay, moving on to the evaluation, speech, language, and swallowing evaluation. We will be looking at OPME, oromotor peripheral examination, structure and function. Basically, we'll be just at rest. How is the structure? Is it symmetrical? Is it deviated? Is it low tone? And function, we'll be discussing further. Mobility, how quickly are they able to move their structures to speech? Chewing, we check for symmetry, strength, and range. They will be able to chew symmetrically. Some people chew on one side and less on the other side. Again, that is a sensory processing issue. How much of it is expressed will tell us whether it's a disorder or not. We look out for atypical chewing patterns, muscle contraction with various food consistency. And then I think chewing part of it, you guys have more knowledge than us. And then body posture is very important. You cannot expect the patient to lie down and chew, halfway sleeping and chew well. There is to be a body stability. The spine has to be stable, neck control has to be there, and then only the focus goes on chewing. Otherwise, the body is busy stabilizing the way they're sitting. The legs have to
sorry to interrupt,
yeah.
Dr. Afreen.
How
many more slides?
How many more slides? I'm almost ending. Yeah. Almost ending. Another 20 slides are there.
Okay, because we're running short of time.
Okay, I'll just run.
And also, I think because of the considerations of the Ramadan, I think we need to be a little considerate.
Okay.
Okay, thank you so much.
Okay, swallowing, we'll be looking at dry swallow. Dry swallow is swallowing your saliva, solids, semi-solids, and liquids. If they're not able to swallow their saliva also, then there's a need for rectal. Lip seal, position of the tongue, containment of food within the mouth and not outside, presence and contraction of orbicularis oris and mentalis muscle, Head movement and coordination of swallowing can be analyzed. Speech evaluation, we have standardized tests that we'll be using, that is photo articulation examination, Fincher Dysarthria assessment, and phonological processes tests can be done. Samples of naming pictures of standard pictures can be taken. Counting numbers 0 to 20, spontaneous speech, and diadochokinetic rate will be assessed. So these are the symmetries and the jaw opening that can be noted when you see the patient. The movement of the lips have to be in sync with the tongue, the way the tongue is moving, and all of that. So for lips, we will be looking at protrusion, retraction, alternating oo, e, oo, e. Oo is for protrusion, retraction is for e, oo, e, oo, e. And then opening and closing of the lips, lateralization and protrusion to right and left, popping of lips, protrusion and retraction can be done, and the speed also can be assessed there. You can ask them to do it faster. So stick out your tongue to cheek on both the sides. A cough and swallow is also, these are, most of the disordered population will have problem in cough and swallow also. Again, for tongue, we've checked for the protrusion, alteration between protrusion and retraction, elevation, and then in and out, protrude the tongue in and out, and then put the tongue to sides of lips, put the tongue on the inside part of the cheek, left and right, and then clean your lips with the tongue. These are the things that mainly will tell us whether there's a deviation and weakness or any problem in the child. Drooling. Why is drooling so important? Poor head control and low tone, weak oral muscular structure, open mouth posture, any enlarged tonsils. This will definitely lead to the child who usually has drooling beyond the age of 2 to 2.5 years of age. The child will end up with a long-standing speech and language disorder. Usually it has to get resolved, or they will stop drooling by the age of 2.5 years. Pacifiers are a big no for us because it changes the shape of your palate, it changes the shape of your tongue, it gives a wrong motoric learning for the tongue, and many reasons for us not to use a pacifier. In this second picture, the third picture, the child has stopped using the pacifier for a span of 1 month, and you can see there's a lot of control over the tongue. How is the posture of her face, and the tonicity in her face is also changed. Like I discussed before, depending on the malocclusions, whether it's an overbite, underbite, the posture of the body also moves. And again, if the body is not stable, we cannot expect speech, because speech is a very fine motor activity. This is something I wanted everybody to tell, if they are able to understand what is the problem in the first picture, and afterwards what has happened. Can I move on?
Yes, Afreen. I think.
Yeah. So this is an infant, a newborn infant who has a tongue tie. And once the tongue tie is released, the tonicity and the overall oral structure you can see. And there are many parents who come back to us when they say that when the tongue tie is released, I'll be coming back to tongue tie again. When the tongue tie is released, the amount of milk that the child is taking just before and after is remarkably huge. There's a huge difference that the mothers can make out, and the latch is better. Everything followed by feeding is much better. How the facial structures change when the tongue is in the correct posture. The tongue should, when they are at rest, the tongue should touch the palate, and there should be a seal. versus when it is not. What are some of the possible things that you can notice when tongue tie is missed or misunderstood? How will you know whether the child is having a tongue tie, the baby or the child? They cannot open the mouth wide enough. This is for both tongue tie and lip tie. Cannot open mouth wide enough, bleeding, chapped nipples, slow weight gain, drastic drop in weight, acid reflux, colic, snoring, and open mouth breathing, major nursing strike, supply decreases by 6 to 12 weeks drastically, lip blisters, sucking blisters. They'll have major issues sucking. Potential impacts of high narrow palate will lead to nasal breathing, becomes difficult for palate to expand, to reach palate for speech also. Feeding difficulties may arise due to difficulty with suction of nipple during breast and bottle feeding. Because nasal passages tend to be smaller, congestion can linger. Potential for sleep disorders and breathing, snoring can occur. May struggle producing certain speech sound. Increased risk of poor oral health due to teeth crowding. Potential feeding difficulties due to frostbite impact on chewing will be seen when there is a narrow palate. And since April is a National Autism Awareness Month, ma'am wanted me to just touch on it. Autism is a developmental disability and it begins during very early developmental years. By the age of 3, their DSM suggests us to diagnose them with autism, but a few of the characteristics, they are most of the time congenital, and they can be seen on as they develop, and at as early as 3 months to 6 months of age, children can be, you can recognize and say they're at risk for autism. Autism is not caused by poor parenting, trauma, abuse, or neglect. Boys are more at risk, 2.3% more at risk than the girls. Recent data indicates autism impacts 1 in 58 children. So it is very common these days. Autism is not a mental or emotional illness. And I would like to say, as an awareness program, autism is a part of the child or the individual, and it is not appreciated to say he is autistic. Instead, to say he has autism or he is a person with autism, because he is just a part of it. Like you have hands, legs, everything. So you are a person with limbs. So it's not right to say and characterize. Autism is not the individual, basically. So sensory processing disorders are also a part of developmental disability. You can say they're easily overwhelmed by crowded places. They'll have difficulty climbing stairs. They'll have difficulty getting their hair brushed, changing clothes. They'll always want to chew on different materials or chew on the same product, whether it's a teether or chewing tube or any of the chewing devices. They have poor fine and gross motor skills like buttoning, wearing shoes, tying shoelaces. They enjoy deep pressure most of the time. They are clumsy. Like I said, they don't like to climb stairs. They bump into things. They have trouble focusing, concentrating, and they are sensitive to loud sounds. Moving on to early intervention, children learn 80% of their language by the age of 3. So this is why early intervention is very, very important. Like I said earlier, each day they learn 50 new words. So early intervention is very important. When should I be concerned about my child's speech and language development? At the age of 1, he's not eating what is put on the dining table that is being eaten by everybody else. So eating and drinking, whatever is being had by others. Not responding to environment and sounds and familiar sounds, like mothers calling. Generally, children love to hear their mother, and he doesn't respond. Not enjoying and interacting with parent or caregiver. They're busy in their own world basically. And these days they give screen. They're busy in the screen. They don't want to respond. Not babbling and playing with sounds. There's some amount of sounds that the child has to say. Not showing understanding of familiar routine, bath time, bedtime, etc. By the age of 2, need a lot of extra cues to help them understand simple naming words, like even to recognize their mother, they will have difficulty. Not interacting with familiar adults, not attempting to use any words at all. They are very happy because parents generally, they'll be fed on time, they'll be cleaned on time, slept on time and everything. There's no scope for them to be given to communicate. Only if you put the child a little hungry, half an hour late, the child will come back and running and ask, Mama, give me food. So that is the latest trend that parent is going through. Has difficulty understanding action words such as jump, wash, sit, using only single words or 2-word phrases, often inconsistent of naming nouns rather than action words. Uses learned phrases and sentences in many situations, even when not appropriate. Those things that are learned on videos, they'll be doing it. They'll be using those phrases. Speech is unclear even to a familiar adult. At the age of 4, difficulty understanding instructions that include words such as big, little, in, on, under. Only understands, uses a small vocabulary, not able to understand or take part in conversations about past, future, and present. If, for example, the child has gone to park, he's not able to come back and tell stories about what happened at park. Is not asking and answering questions, has difficulty in mixing with other children. Keeping COVID in mind, most of the children, typically developing children, also have difficulty with socializing these days. Has difficulty with pronunciation, ta and ra. These are ta and ra are acquired late, so that is all right. Sentences are not well formed. Okay, about 70 to 80% of late talkers recover and pick up their age-adequate language skills when they go to preschool. But 30 to 20% of the late talkers, they do not go into, they don't pick up their speech and language skills and need intervention. Since we don't know which is the 20 to 30%, we definitely need to help them, because if speech is delayed, the literacy, the language, the mathematical skills, everything gets delayed. So how can we encourage a late talker? Don't endlessly ask your child, what is this? Instead say, this is a boy or this is a car. Make eye contact, look into his eye and talk to him. Use a lot of loud expressions. Oh, wow, you did it. Excellent work. Okay, shall we do this also? And things of that sort. Look into the child's eye. Most of the parents are busy looking at the screen. Talk about what you're doing and talk about what your child is doing. Add one word to the word your child says. If the child says ball, you can say, oh, you want the red ball. Stress on the red. Or you want the big ball. Use a lot of repetitions. When it is done through play, the child requires about 20 repetitions for the child to understand and make a synapse in the brain, versus when it is done in an unpleasant way, it requires 400 repetitions. So a very joyful way of learning through play is what we encourage. Use give and take. Read to your child and leave spaces so they can fill in, like, oh, this child is going to, and then wait, the picture will tell he's going to eat or jump or cry. Pause and wait for the child, and then you start talking, count your steps, find opportunities to interact with your child. So who needs a speech language pathologist? This is an overview of what we treat, and from infancy, newborn till geriatric, we treat all these disorders. So conclusion is absence of oral health will promote negative impacts on quality of life of children and patients because it compromises the development of chewing function, speech, and it can interfere with psychological factors as discussed by Jasna that impair the child's and patient's performance at school and workspace. When phonological process disorder is left untreated, like I said, when the speech is not addressed, the child will have learning disability. It is a spectrum. And this is because of the inadequate speech and language skills. Because of the negative reflection of oral health on poor quality of life of children, this is a study that I had come across, aged between 2 to 5 in their family. The patients with toothache had difficulty to eat and the frustration was there. For family members, the feeling of guilt followed by discomfort about the patient's oral health and were most significant. The interdisciplinary interaction between dentistry and speech language pathology is important for obtaining successful clinical treatment, which involves both preventive and curative approaches, helping in improvement of phonetic and myofunctional adaptation. Thus, the patient can gain a considerable improvement in oral health and development of speech, chewing, and self-esteem. These are my details. I will put in my mail ID in the chat box if there are any queries. And
Thank you, Mrs. Afreen.
thank you. Thank you.
Can we stop your screen share and we'll have Dr. Amina on session.
I must congratulate both the speakers, despite like the time we are going through the Ramzan time. You put in so much of effort that it is mind blowing. Dr. Afreen, your presentation was such an elaborate presentation. I wish that we have some kind of lectures during not saying the post-graduation, during a graduation time also, like during the case history, like you can just, I must request you, like I'm requesting you, can you just make your presentation in a chapter form that can be included in a pedo textbook, so that while taking the case history, we can get an idea ki how the speech of the child, like we communicate, because we are in the behavior management, we are dependent upon the communication. That is a foundation of any kind of managing therapies, and so much of communication is dependent upon the speech. So this presentation is indeed going to help us. Like I am, like my personal is that I'm really benefited with this presentation of yours. And Dr. Jasna, yours was such a crisp presentation. Okay, there were some queries from the from the audience. But I think you must have also gone through it. If you feel that you can answer them, because most of these queries, they have been answered in Dr. Afreen's presentation. But even then, if you want to elaborate something about the, see, the entire apparatus of the speech is located in the oral cavity. So dentist का तो involvement बनता है कि ठीक है, आपके speech में आपका tongue है, palate है, throat है, ठीक है, teeth है, वो सारा कुछ जो है, the dentists are also dealing in some other way. So there has to be some kind of an involvement in the dentist. Dentist can diagnose a speech and can refer to you, or as a speech therapist, you can come across some dental anomaly which you feel that is interfering with the correct speech, or it is causing some disorder in the speech, and you can refer to the dentist. But so it is a good collaboration we can think of, and I think it's one of the kind of a presentation where the interdisciplinary about a dentist, because बच्चा जो सबसे पहले जाएगा एक जनरल डेंटिस्ट, मोस्टली दे विल बी रेफर टू ए पीरियोडोंटिस्ट. एक जनरल डेंटिस्ट को लगेगा नहीं हैंडल कर पाया, स्पीच नहीं हो पा रहा, दे विल रेफर टू ए पीरियोडोंटिस्ट. आई वुड से categorically that periodontist can work in collaboration with you people, so that we can come up with a future prospect where we can work and we can come up with some ideas that this area is not neglected. ये नहीं कि बच्चा 4, 6 साल, 8 साल का हो जाए, then the child is being referred to a speech therapist. It can be detected earlier because we are seeing the patient in the beginning. So it was a good attempt. I must congratulate Dr. Gauzia also for bringing in this topic. For her time, you know, her efforts are like worth praising. I really appreciate your this thing. So how nicely you think about the ideas and then you put up your efforts, your ideas, and you brought such brilliant presenters today and this afternoon. I really enjoyed this thing.
Thank you so much, ma'am. We'll just quickly go through the questions if it's possible. So Dr. Nair, questions, vocal hygiene. How do we identify this aspect and how exactly do we emphasize on voice rest? I think.
Yes. So basically, vocal hygiene that I mentioned is to have a good quality of voice. So vocal hygiene is not something that a patient should only be following. It's something that every one of us should be following. So having correct the amount of water, just sipping in some amount of water so that we can maintain our voice quality. And not all the time using our voice abusively. Like there's a lot of background noise. So this is a tip that I can give to the dentist here, because there's a lot of noise always in the dental setup. So most of the time what happens, you will be talking to the patients or you will be talking to each other. You would not realize that you're raising your voice and speaking. So this will have an effect on your voice. And because of which you can develop vocal nodules and vocal polyp. And there are many other things which are pathologically related to the voice quality. But apart from that, when a patient comes to your setup and you see the child's voice is too bad, he's not able to speak well, it's having some kind of effect, one thing definitely you have to refer. But in case, apart from that, they're not able to do anything, then definitely ask them to take some amount of voice rest till the time they're going to get the help, and that should be at the earliest, and to follow good vocal hygiene. So when I say voice rest, you might sometimes think, okay, you can whisper. So it's very important the moment you say the patient, you take voice rest, make sure that you tell them not to whisper. Because when you're going to whisper, that is going to put a lot of adverse effect on the vocal cords, and that is going to affect the voice again even more. Another thing that you should be careful is most of the time when our voice is not good, we have this tendency to keep clearing our throat. Throat clearing is something that you should avoid, like all the time. That is something which are going to affect the vocal cords badly, and that itself will cause a lot of problems further. The other things that you can follow is there's a misconception like, okay, I can have a lot of strepsils all the time. Let me drink a lot of citrus items. This is going to make my voice good. Let me drink something very hot, pine do, and let me have more of coffee. So all these things are going to again affect the voice. So this, as a professional, we should also be following, and we can also guide our patients to follow these tips. And keep sipping in water. It's not that you have to keep waiting that you feel thirsty and I drink, main to bahut pani pita hu, like I can drink like 3-4 glasses of water at a stretch. That does not make sense. It is sipping. And these are the main things that that can help. And voice rest with respect to complete rest for at least a week, depending on the pathology and the kind of voice therapy, the exercises that we are doing for the patient, it will vary. So this is in just about what is the vocal hygiene and what you can follow, the basic tips. And also avoid spicy and very oily foods. That is also recommended. You can go for more steamed food. That is also good.
Yeah, thank you.
Can I come in? I have a query, like I want to ask Dr. Afreen, like sometime we come across cases like 4 years, 5 years, 7, 8 years, and the parents say कि बच्चे की आवाज थोड़ा सा funny है, like the child is being bullying at, like there's a bullying at school because the child voice is very like funny, the boy is speaking like in a very feminine tone. So what do we suggest in such cases?
Generally,
बच्चे की आवाज थोड़ी सी ना feminine, very shrill voice, मतलब कि like it's very annoying to others. They're the target of the bullying or some fun making. And we have seen also, like as an adult also, some people, they don't sound pleasant while talking. So how, like during the early stage, how we can help in correcting that?
See, there's a normal development of vocal structures that happens. The length of the vocal folds along with the whole body also increases. So that directly hampers on the, the longer the vocal folds are, the higher it is going to be. It is all in the basic mechanism of how vocal folds move. But at the age of 6, all children should have a high-pitched voice. Much later in their adolescence, when they hit puberty, the Adam's apple falls down and then the voice becomes lower. There's a mass gain in the vocal folds that happens. Because of the mass gain, the voice becomes low. So it's a natural growth process that happens. At the age of 6, we need to counsel the child, saying it doesn't matter. That is how everybody's voice is at that age. And then don't bother, because I think bullying is not just with respect to voice. Even if the child is walking and talking, everything is fine. Today's generation has it. They want to put the child down in every possible way. I think that has got to do a lot with
sometimes that persists. Sometimes that persists. Sometimes that persists.
And
that tone, that the style of talking persists. So how we know that is the father also speak like this.
Yes.
The mother, typically the father has that typical way of speaking that are very feminine, very soft, and the child is also picking up. So how we can like
that is called pubophonia. That is called pubophonia when a male talks like a female, and it's called androphonia when a female talks like a male, and that has a proper treatment strategies. Like I said earlier, a few of them learn their compensatory strategies. They'll cough and then they'll start getting low voice in that cough and then they'll start talking, roughly. But that is not the right way to address this issue. Some trial and error karke patients learn that, but then there is a proper method. Again, they have to be referred to a speech language pathologist. Just counseling and then slight massages most of the time will help them to move on to a lower voice, that is typically normal voice, as you would say. So with just 2-3 sessions, they'll be able to achieve 50% of their male voice. But to stabilize it, because over 30-35 years, this man has been speaking like a woman, and it's again a motor learning process.
Not woman, it is just like it's a very shrill voice, like it's like
exactly
it is some kind of very shrill voice.
Yes.
Very,
that is why there are treatment strategies where massages, like I said, massages, there are digital manipulation techniques, and then there is cough and phonate is the last resort most of the SLPs take, because coughing is a natural reflex and it does require the same muscles. But then to stabilize, they will achieve within 2 days the male voice, but to stabilize it takes more time, because again it's 35 years of speaking like a woman, and we are not doing magic basically.
Now, at least we can counsel the parents, because
that
might transmit to them, because the child is going to observe his or her parents, how they speak, how they address. So they will pick up that kind of a speech dialect kind of a thing.
Yes. So
just to add on, definitely the pubophonia is also with respect to the psychological viewpoint. It is also said that the boys, especially during the adolescence phase, if they're overly attached to their mother, there's a tendency for them to develop this kind of pubophonic voice. So even counseling is very important in this particular, and most of the pubophonics that we have come across in the clinical setup also, they're not very open, they're very shy.
Yes, they're very reserved. They reserve.
So
because they know, because the moment they speak, there is a lot of mimicry happen, that they complain that they are being bullied at the workplace or at their school.
So the moment we do the therapy, so it's only if you are going to target the voice, it's not going to stay for longer. So only if you involve the counseling in them, only then the gained voice. It's very easy to gain the voice. Even maybe sometimes in the first setup or the second setup, we get the voice, the male voice. It's very good. But immediately in another 1 hour's time, it goes off. So to maintain the voice quality is very difficult. So this should be again a combined strategy, and counseling definitely is important along with voice therapy techniques, which are definitely there. So you can refer them, and many of them have actually, especially the college going students, it's at that particular point of time. So that's the mistake that happens. Only once they enter the college and then they have to face some interviews. That's when the parents and they themselves think, abhi to kuch karna hai. And that becomes too late, because to suddenly change the voice, it becomes difficult. So if we can catch them at the earliest, around 14 to 15 years or 16 years, when exactly the changes are happening, until 18 years, it's not changing, immediately start the therapy, and definitely it will show wonders.
Yeah.
One more thing I would like to add regarding the child with age range of 6-7 years, counseling is very important, because long-standing bullying, there are few patients that I have come across who are 20, 22 with long-standing bullying in background. I've seen them only recently, but they are having severe depression. I think there Jasna can comment better, because counseling, instilling the confidence in these children, what is put in the crib?
Actually, the whole essence of me to have an interest, to have something, some hands-on in counseling part of it is basically because when in my college days also, when we used to target like the speech pathology or the hearing patients, etc., they have some problem. It's so easy for us to make a provisional diagnosis, but to handle them, and then we have options. Okay, so and so, so and so, you wear a hearing aid. But it's not, when I started practicing myself, I understood that though you have these technologies, you just have to tell them, okay, wear the hearing aid, but to actually make the patient understand its importance, to convince them that you have been having this ability for such a long time and it's already going away from you, it's becoming a difficulty, to make them understand. And especially the mothers, most of the time, sometimes when we move out from the speech therapy sessions, I have seen the mothers, especially with the autistic, because even having normal children, we lose our patients most of the time. That's a fact. It's a reality. So they'll be pinching them, they'll be hitting them very badly. So there'll be a lot of things. So it's not just the child that should be given the speech therapy, the mother and the father and the entire family also requires good amount of counseling and support. Only then you can see the changes happening in the child. So that's a very important thing, and that's something which we lack. We always make a progress during our college days. We make only the progress of the child. Okay, the child is doing so and so. But what about the mother's mental health? What is happening in the family background? Why is this child not improving? Is it only the fault of the speech therapist? Is it the wrong techniques? Or is it something beyond? And definitely that something beyond is a good moral support system. The support system is very essential. That itself can do a lot of changes.
Definitely.
Yeah.
Support system is the
Yeah. What I feel is it can be it is preventable. We can prevent the extent of the damage if it is handled or intercepted at a very early age. Dr. Qasim, there's one question that can you please share one of your most challenging experiences with the kids, with the speech issues? How did you convey the treatment plan? How challenging was their cooperation with the dental treatment, like any of you? So that experience of you can be a learning experience for us. Any experience of yours?
I think the gestures, the sign language come into play, the non-verbal communication method, the patting, the smile. The first game plan is the smile,
the communication is the crux for any kind of a. We begin a treatment, first we develop a rapport, and the rapport के लिए आपकी सबसे पहले आपसे बातचीत करनी होती है. So the verbal communication and the non-verbal communication.
So I think the game plan changes. Suddenly you start using your gestures, your smiles, your expressions, facial expressions, looking more into the eye contacts, and then coming up to their levels. And of course, you're getting cues from your parents also, the parents of the child. How is normally he? That is what helps us in ASD kids, especially the autism spectrum kids who are non-verbal. And also in the selective mutism, which I had this doubt, how the speech pathologist or even the audiologist would want us dentists to segregate these kids who are selectively mute when they come into stranger zone or claustrophobic zone like our dental practice, from actual anatomical or the pathological speech pathology or audiology. I need help in this because I feel that's challenging. Getting them slowly into confidence and letting them speak is something which we will learn later. But of course, how do you segregate if the child is selectively mute? Is the child able to hear us in first place, understand or comprehend the instructions which I'm giving, and just selectively mute because of this? Or ideally, pathologically, the child is not perceiving the commands because of audiological problem or speech pathological problem. I think that is one question which is lingering on my mind of late.
So the moment he walks out of your room or your clinic, he'll start talking. That is one major thing. There is two things here. One is pathological selective mutism, and then there is non-pathological selective mutism. Even we become selectively mute when we meet new people, koi aa raha hai and all. We are very, that is something you'll
new environment for it is a foreign environment for them.
Yes.
So can we, if we interact in their mother language, will it help?
Yes, definitely. Talking in mother tongue, the child will give out expressions immediately. You speak in their language. In kanda marta idya, you talk like he'll move his eyes. There are a lot of non-verbal cues that you can pick up from the child immediately. And other than that, you can play music, what the child likes, and then try to know whether it is an hearing disability or a child who's selectively quiet there. Other than that, you can maybe, there are a lot of sounds in your dental setup. I don't know how you can reduce that sound. Maybe you can just play games with it. We'll just play with that water. I don't know what is that. You can make it very like ma'am said, rapport building, get the child very comfortable and all of that, and then you can see, you can ask the parent for what he likes. Most of the days all children are having few favorite videos and things of that. If you want your work to be done, maybe you can play, sing those songs, not put visually, but maybe sing those songs and all that.
Yeah. How do we
I can ask Dr. Gauzia, you can start the pre-appointment management. Like whenever you fix an appointment, you just speak to the parents, what is his favorite color, what annoys him the most, and what he's fond of, and what are his favorite games, toys, his nickname. So when the child comes to you, just surprise him by calling him by his nickname, or you start addressing his favorite. I met your teacher, favorite friend. I met him in a park, blah, blah, blah. You can just make a story, and then the child is going to be surprised. Okay, how do you know? Because the children are very intrigued. How do you know my friend? How do you know the name of my school? But then he'll be really surprised. He says, okay, I came to your school. So this may also break that ice. Because the child is
very interesting.
Sorry, since there's a talk on the tongue, now we have these intercaste marriages or interlingual marriages. So the father's like, in Kerala marrying a Malayali marrying a Tamilian, and the child is, so which mother tongue or the father tongue are we going to communicate and break the so-called ice with the, when we are bonding with the child? That is also, because now it is, even with the spectrum children, we understand that the therapists are speaking only in English, so the child follows English irrespective of the child speaking in Urdu at home. I mean, there is spoken Urdu or any other language. They follow English. So how are these things to be sorted out here? The parents need to be addressed, or the child, we just have to accept the therapist's language or the parents' language?
Studies have shown that being multilingual has its advantages, and all languages have universal rules that are there, and all languages are equally complex to learn. There's a universal pattern, and there's a device in our brain that detects that and catches language. So there's nothing called as use one language. I would suggest use multiple language. But when you know that the child is having some disability, or he's finding it difficult to pick up one language, stick to one standard language, whether it is mother tongue. If you're taking therapy at home, there are everybody else speaks Urdu, and you're taking therapy in English, the child as it is has difficulty picking up one language. You're speaking mother, amma, ammi, everything, and confusing the poor child with so many words. So we suggest to the therapist has to learn the language. Basically, they have to, if you want, because you won't find only English speaking population, basically, right? So the therapist is at fault there, not the child, not the family. We have to find a common one language. We suggest usually depends on the region. If there is Kannada medium school dominant there, we suggest go ahead with Kannada. If it is more like Bangalore metropolitan city where English is dominant, we suggest go ahead with English. Because ultimately he has to go to school, and then he has to pick up that medium of language. So that is something we solve that way. I don't know if Jasna has some other opinions on this.
No. Actually, when I do the same, but there is a difference in opinion regarding this. Even the patients, because they also keep changing the therapist sometimes. So when I tell them you can use two languages, So one thing is definitely, even for adults, for normals also, the more you're getting exposed to a new language, the chances of your brain development and you being much more superior is a known fact. Second thing, if the child is definitely diagnosed and you feel that the child is definitely having a problem, then you can focus on one language. But I do make sure to tell the patients that the basic commands, the basic instructions, and the very commonly used words, that you can definitely tell it in the mother tongue also, because definitely the grandparents want to talk to the child and they have to go back to their hometown and things like that. So once they are there, the whole intention of having the speech therapy is to communicate. And then you teach him a language wherein the people in and around him, the friends doesn't know, or the whole family doesn't know what he's telling. And then he's talking very well in English. It doesn't make sense. So he has to hear to that language also. But again, for his other development, because English being very commonly used and it becomes easy for the child to communicate, we can focus. And once you see the child is making progress, you can keep introducing the mother tongue also. That would not be a problem. But if it is any other issues, or it's just because the parents are talking two different languages, you don't have to have a fight over it. The more, the better. That's what
Exactly.
I'll take a parent whom all of us are familiar. This is Sai Jyoti. Ma'am, can you unmute yourself and ask your query? You've raised your hand. Yes, ma'am.
Yes, thank you so much, ma'am, for giving me the chance. And ma'am, and Gosha, ma'am, like you, for you, my Chinmay, my daughter, has been a patient since when she was 2.5. And Madam Jasna, like she was the one to take out words from my daughter. When I first went to her, she was just babbling ababa. That's it. And she was the one. And I'm so thankful to her. Still now, like I'm not getting chance to go to her. Like I had to stop because of some personal reason. And ma'am just now told that yes, about the language which has to be spoken to a kid. Yeah, rightly she said. Even she guided me also that everyone insisted at home that I should speak mother tongue with my daughter. But I was not so very, like my Kannada is not so good because of the education where I took, like it was in Kendra Vidyalaya. It was not like Kannada is not encouraged there. Hindi and English is encouraged. So I just I just asked my doubt. Then she told, okay, in that case, what you do is everyone speak with her in Kannada. You at least one person speak in English, so that when she steps in the nursery or preschool, she doesn't have to face the frustration. And this is the rightly thing, like she told, and I'm so thankful to her. Now my daughter, she's not facing any kind of frustration. She's just able to understand whatever everyone is asking. She gave an example that if someone asks you, like you ask your daughter, they will not ask her like nin hesarenu. First they will ask, what is your name? That is the first thing everyone will do. Even a Kannada people will, like, even though their mother tongue is Kannada, they will ask that. So I just took this example and I started speaking with her, though she told that come, you say come and ba. Both the things she'll be understanding. And I rightly, like whatever now also, it keeps me reminding everything, whatever tips she had told, and really, I'm so thankful to.
Thank you so much. I really wasn't aware that you were there in the background. So this is demonstrated. This is something which we have done. So it's not just verbal. So it's actions that speak louder. So we have a parent who has been with us for a long time, and her child is differently blessed, and she's been doing wonderful now. Though many of them told that she would not be able to succeed, she won't be able to go to school, a lot of the issues, but so it's the willpower, so, and the therapist, so all together, it definitely makes a difference.
And timely, like my daughter, she favorite dentist is Gosha ma'am. Now also I have saved just to show her, like whenever she remembers her, and she timely advises me what I have to do. And I was supposed to go to her just now, like because of some reason I couldn't go. And she rightly suggests me, advises me what I have to do. And I'm so thankful, ma'am. Thank you so much.
You see the smart colleagues I work with. So it just shows or anybody. So I just have one last question before wrapping up. And thank you, Sai Jyoti. Thank you
Yeah,
so much.
thank you so much, ma'am.
So foreign body, I have this parent, a typical parent-son combination, who comes with a complaint of, this is my personal experience actually. So they come with a complaint of tooth pain. Clinically, radiographically, there's no such signs which I can identify. But later, I think the second visit, I realized that the child was quite attached to the mom, and I started checking his ears in particular. So I realized the child is imitating the mom in the imitation, since the child is very young, the boy, this is a boy, who's very young, and he starts imitating the mother. So the cream which the mother uses for cosmetics is being inadvertently put into his ears. And that is sort of caused confusion and infection, which was neglected by the mom. And that was kind of irritating the child. And then later it had to be sent to the ENT referral. Jasna, your take on these, such kind of, foreign.
Yes, ma'am. Yes. So basically, ma'am, during my presentation also, I told that initially when these patients with the eustachian tube problems used to come to us, they used to say there is ear pain, and they used to sometimes tell it's tinnitus is present and it's so painful, it's so disturbing and things like that. We used to work, I used to work with the doctor as well. So ma'am used to also discuss, we used to put them on medications, but they keep coming because it's very annoying. And the pain is also not going. And ma'am used to also check the ears when we used to do the otoscopic examination, and it's absolutely nothing. So it's later on when we found that that's exactly why I highlighted that point also during the presentation. So when there is a caries, this is what they do. They do not chew on that particular side. So what and then what I started doing after that experience that we had from 2 to 3 patients, it was a learning lesson for us. So even if the patient doesn't have any other complaints or it's something associated and looks something like this, I make sure to ask them, did you anytime undergo any dental treatment of late, or has anything been prescribed to you? So sometimes they say, yes, I have to go for the further treatment. I'm on the process, or I stopped it because of pain, or I'm scared, so things like that. So what I would suggest is, as dentist, even you should do an otoscope examination. Have an otoscope. It's not necessary that you do it or it'll waste your time or something. No, just do it. Especially if it is a child. Even if if the case is known to you, you think it's only the dental issue, just check the ears. You can sometimes see there's a lot of impacted wax also. For that also, you can give them a reference. Maybe putting a solivax, because even 10 to 20 dB of difference, the moment you have some cold or you have an impacted wax, which is really hard and it's not going off, so that will definitely cut down the sound by 15 to 20 dB, definitely. So this one for us, maybe it does not make a difference, but for a small child who is in the language development process, even if the child is not hearing clearly, even that 15 to 20 dB will matter. So by just doing a simple otoscopic examination, we can identify this basic problem, and with that referral, a cleanup can be done or the medication can be given, and both the problems can be solved. So it can again be a combined multidisciplinary approach for the overall. So I think you can all start off with this otoscopic examination and help many kids. Maybe because at the same time that they have a dental issue, they are having some ear discharge or some ear pain is also there, or the child is already having a cold, and it's at that particular time they have come to you. So there is a lot of fluid in the ear or something like that, and it's already disturbing the child. So at that particular time, you're trying to also do the dental treatment. It's going to be very annoying. So one of the reasons the child is not cooperating or not sitting along well for your treatment is because maybe there is a problem in the ear also, because definitely for your treatments, you have to open the mouth and sit. So that is also there. And again, ma'am, you had asked regarding a child who is not cooperating, what else can you do? Just to quickly add on, what you can do is, if at all you're wearing an apron or a coat, the doctor's coat, remove it, because most of the kids have a imaginary thing that it's something scary. So remove it. Always have some stickers or something very nice with you, so that you can just give it, because that token of simple things are something that they appreciate more. What you can do is ask the mother to sit in the chair first, if at all the child is not cooperating. The moment the mother is sitting, they find it more easy. Oh, okay, this is something that's not going to harm me. Make them feel the instruments, just make them touch it, so they will feel like, oh, this nothing is happening, because most of the time they think that will affect them badly. So just make them touch everything. Isn't it beautiful? Don't you want to do it? And then the other thing is, don't focus on the child a lot more. What normally we do is, the moment the child is not talking, everybody in the family, the mother, the father, the doctor, everybody is putting a lot of pressure ki bolo, mukolo. So that time it's a normal mindset. The moment I say, don't think about Mahatma Gandhi, all of you had just now had a visual imagination of Mahatma Gandhi. So it's the same thing. The moment you say, please open, 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 they'll be more stiff and it makes your problem even more worse. So just divert the attention, make them go outside and come again, or you just move the attention towards from the child. And you can just tell, oh, you have a beautiful voice. How loudly you're talking. Something like that. So the child tries to talk more and cooperate with you better. I hope this will help you, ma'am, in your clinical setup.
Perfect. Yes.
One last thing I want to add is you had asked how to differentially diagnose whether it's a selective mutism or just a child being quiet. So I had mentioned a few red flags, not able to recognize mother's voice and, you know, things of the sort, and milestones. The moment you see the child is not able to walk well, they generally come in by walking, or he's throwing a temper tantrum, you calm him down. And then you see the moment he moves his hands, legs, the overall body will tell whether the child is having, they have different tone altogether. The muscles are floppy, they are drooling all over the place. They are not able to keep the mouth closed. Their mouth is always karke open, tongue is always falling out. The hands are also floppy. The way they walk, the way they sit itself is altogether different. So that way you can make out whether it is a child with disability or no. Long-standing selective mutism, again, it takes experience. What Jasna suggested, those things may open up the child and help you out there. But even for speech language pathologists, that's why we have a provisional diagnosis. We take minimum 6 months before we can diagnose a selective mutism, a child with selective mutism. So the DSM doesn't allow us that way.
I think we are done with the questions.
Yes, it's wonderful.
Ma'am, just to add on with respect to the hyperacusis part also, because most of the time as dentist, you might be coming across such patients quickly. So most of the time, if you can alter between using some amount of hand scaling instruments, that you can, it can be an option. And rather than doing the frequent suctioning, you can just reduce on that. You can ask the patient to spit rapidly, so that at least that much of pressure. And most importantly, it's more than the condition of hyperacusis being eradicated totally, it's the counseling that is important. So it's the response to this particular event, you know, the unpredictable behavior which will happen because of this loud sound, that should be already told to the patient that so and so is happening. And you can give it in lesser doses, like give it at a time, and do not do it continuously. You know, he's having a trouble, let me just finish it off. That will be the normal concept. So just do go very slow, so it can help. Apart from that, there is something called as earplugs that can be recommended. So there are two types. There is the customized one and the one which you can just buy it, handmade, ready-made. So you can go for the customized one. So this will definitely, so this is what we do for normal patients with hyperacusis. So there is the solid earplugs as well as the sleeping earplugs. So based on whatever is the condition, so it is not harmful, it does not pain. So the customized ones are much more easier to use because it will be the size impression of the patient is taken, and we will be making it accordingly. So this will be more beneficial. So there will be a reduction in the sound. So they will feel much more comfortable. And maybe at that particular time, don't do it off at the first setting. If at all you think the patient is having hyperacusis, you can have a word with the doctor, give them some kind of antidepressants or some kind of relaxants, and then start off with the treatment. And you can also put it into sessions, 2 or 3 sessions slowly, so that it becomes easy for you as well, because otherwise they do not cooperate.
Okay.
Anything else?
I think we're done for the day.
Yeah. Okay. Thank you so much, Mrs. Jasna and Mrs. Afreen, and thank you so much, Amina ma'am, for taking.